In part 1, we looked at the importance of maintaining the oxygen to the brain using the ABC approach. We also considered the treatment of shock and of burns. In part 2, we shall look at fractures, other medical conditions such as diabetes and asthma, and at moving casualties. This video is modular, and we suggest that you look at one section at a time and then consult the supporting booklet, which expands on the points made in the video. Effective use of this training material will help you to deliver basic first aid to casualties on board. As a trained first aider, one of the most common injuries you'll have to deal with is one that happens like this. The majority of bone and muscle injuries are not life-threatening, but multiple fractures and spinal injuries can be. The most common type of bone injury is a closed fracture. In this case, it's the lower leg. It's a relatively straightforward fracture, except that there may be more than one broken bone. The lower leg contains two bones, the tibia and the fibula. If only one is broken, the other may act as a natural splint. If both are broken, it's likely that the leg will be distorted. Before starting any first aid, you must first remember to check for dangers to yourself and the casualty. In this case, as the leg is clearly distorted, it will need traction. This means realigning the broken bone so that it can reunite. While one person steadies the leg well above the break, the other pulls gently on the foot until the leg is straight again. This brings the ends of the broken bones back into place. Otherwise, the leg will either remain deformed or will have to be broken and reset at a later date. The next step is to apply a splint. Many ships carry inflatable splints. These are easy to put on and allow you to see the state of the injury. It should be long enough to extend beyond the joints at the end of the fractured bone. Every half hour, the pressure should be reduced for 5 minutes and then restored.
Right. Make sure you support the ankle.
You will also need to check the circulation and colour every 10 minutes. Press the patient's toe for 5 seconds, and after releasing, the colour should return in 2 seconds if normal. Also, test the patient's response to stimulus. If the limb is to stay splinted for longer periods, you need a conventional splint made of well-padded lengths of timber or strong cardboard. One goes under the leg, the other two go on either side. They must extend from the middle of the thigh to beyond the heel. Make sure there is plenty of padding. Then, using sheeting or bandages, tie the splints firmly together. Make sure you don't tie over the breakage points, or you'll hurt the casualty. Look for signs of shock. They are taught in part 1. If the victim has broken both upper legs, you should automatically suspect a pelvic fracture as well. This means you must look for signs of shock. Then, apply well-padded splints extending from ankles to the victim's armpits. Make sure there is plenty of padding between their ankles, knees and thighs. To keep their feet together, tie a bandage in a figure of 8 around their feet and ankles. The same basic techniques apply to broken arm bones. The key signs are swelling, deformity, and loss of function. After treating the casualty for pain, apply traction if necessary to straighten the arm. Be firm, but gentle. There are nerves and blood vessels close to the bone. Next, apply a splint to the outer surface of the arm, or you can splint the arm to the body.
You just try to bend your arm, okay? Yeah. That's it. As best you can.
If the elbow bends easily without causing pain, put the splinted arm into a sling. Take a large triangular bandage or clean piece of cloth and spread it between the bent arm and the body. Put one end up around the back of the neck to the injured side. Bring the lower end of the bandage up over the forearm to meet the other end at the shoulder. Tie a reef knot at the hollow over the collarbone on the injured side and tuck the ends underneath. Bring the point in front of the elbow. Tuck any loose bandage underneath it, above the elbow, with a safety pin.
Right.
If the elbow won't bend easily, you need to use long padded splints on the outer and inner surfaces of the arm, bound together as demonstrated with the leg splint.
I need to put a splint underneath it.
If the lower arm is broken, the same principles apply. Put the arm in traction if necessary, then fit splints to the top and bottom of the arm. They should extend from beyond the elbow to the middle of the fingers. When the splint is in place, fit a sling as shown earlier. The hand should be raised about 10 centimeters higher than the elbow. If it's a broken wrist, you should not attempt to manipulate or straighten it. Fit a padded splint extending from the middle of the lower arm to beyond the tips of the fingers. Place a firm ball of gauze under the casualty's fingers to hold the hand in a cupped position. In cases like these, seek radiomedical advice immediately, as further emergency treatment may be required to preserve the hand's function. A potentially much more dangerous injury is a fractured pelvis, which is often present when both upper legs are fractured. It can cause internal bleeding into the pelvic cavity and the lower abdomen. To test for a pelvic fracture, press gently on the front of the hip bones, downwards and inwards. Do this test once only. There will be pain and possible movement if the pelvis is fractured. You need to take great care in moving the victim. If he has internal bleeding, he will start to go into shock. So watch for the signs and monitor how his condition changes. If he passes urine, collect it and test it for the presence of blood if the kit is available. When you have completed your initial assessment, get radiomedical help. Open fractures present the additional problems of bleeding and exposed bone and tissue with high risk of infection. The first priority is to control the bleeding and get help. Here, one of the bones in the lower leg has punctured the surrounding tissue and skin and is now exposed. First, you should ensure that you have the infection risk and the bleeding under control. Your next job will be to get the bone back again. With an open fracture, the bone may be contaminated by contact with the skin surface and the air. There will also be a flesh wound and bleeding to treat. Open fractures are distressing to see and deal with. As in any first aid situation, it's important that you remain calm and reassure the casualty, who will be anxious and in great pain. Treating an open fracture may involve the additional problems of blood loss and infection. If possible, get someone to support the limb while you work on the wound. The casualty should not be moved unless he is in great danger. Make sure that the limb is supported in the way that causes the least pain. On the rare occasions that the bleeding is severe, use a sterile dressing or a clean pad and press down on either side of the exposed bone. Now, place padding over and around the dressing. With a protruding bone, build up the pads until you can bandage over them. Don't use anything fluffy for this, because it will stick to the wound and the bone. When you're satisfied that the bleeding is under control, immobilize the limb. When the limb is secure, get the victim to the medical room or their cabin.
He had an accident. I dressed the wound, but there's some bone coming out of it, so you have to keep it.
Okay.
Check for signs of shock and other injuries. Then get radiomedical help. The shore-based doctor may well advise traction. If the victim is showing signs of shock, the doctor will advise you how to proceed. If you're on a passenger ship, the medical officer or doctor will know what to do. It's also essential to check the pulse regularly beyond the wound, away from the heart. The doctor would then instruct you how to deal with it. A dislocation presents similar problems to a fracture, and the treatment is basically the same. In this case, it's a dislocated shoulder caused by a heavy blow. It's extremely painful, especially if the victim tries to move the joint. A typical dislocation causes swelling and a misshapen appearance. It's best to keep the casualty in a sitting-up position. Place some loose padding about the size of a fist in his armpit to avoid skin-to-skin contact. Then, tie the arm to the body just as you would with a fracture. Unless the person knows he has a recurrent dislocation and can tell you what to do, you should not attempt to relocate it. Now get radiomedical advice. A dislocated finger is much simpler. If possible, you should have the injury x-rayed before attempting any reduction. But if this is days away, then start by bending the casualty's elbow to a right angle, if this is possible. One person then pulls firmly on the finger, while the other pulls in the opposite direction on the elbow. Keep this up for at least a minute to get the ends of the bones apart. Then, gently ease the joint back into its normal position. When you're satisfied that the joint is back in place, immobilize the finger by fixing it to a splint and strapping it to its neighbor. Leave it for 24 hours. After 24 hours, remove the strapping and ask the patient to exercise the finger carefully. At the next port, make sure the casualty gets it x-rayed and seeks any further medical advice.
Is that good? Yeah, good.
The most serious fractures you could face are those that involve the spine. Always suspect spinal injury when someone has fallen more than their own height. If the vertebrae and discs of the spinal column are damaged, the casualty could experience pain in the neck or in the back at the level of the injury. You can sometimes feel a swelling over the spine, and it can be painful when touched. Spinal cord damage is a much more serious problem because it is the highway for messages between the brain and the rest of the body. If it is pinched by a displaced disc, you can expect some form of temporary nervous damage. But if it is severed, the result can be paralysis or even death.
Okay, just lie as still as you can here, all right?
When you have reason to suspect spinal injury, your first priority is to avoid any further movement of the spine and the neck. Hold the neck, keep him still, and don't try to shift him until you have plenty of help. Don't let go. Shout for help until someone comes.
There's been an accident. Can somebody help me, please? Can you come and stabilise his head for me? I think he's here to the back. Okay. All right, I'm gonna have to smell it now. I'm going to have a look to see if it hurts anywhere, so can you tell me if it hurts? No? You look at me, and alright. That hurts.
A quick test is to see if the victim has lost any sensation in his body. If he has, the spinal cord has almost certainly been damaged somewhere. If his neck is injured, it is possible that he will have breathing problems.
No, you can't feel alright, mate. Don't worry. Don't worry about it. You know?
But even if there are no signs, you should still proceed on the assumption that his spine is injured. Any lack of sensation may mask other injuries, especially abdominal pain.
Okay, I'll just check your arm, alright? Can you squeeze my hand for me? Okay, I'm just going to get the collars and the oxygen. I'll be back in a minute. Keep them as still as you can. Okay, what we need to do first is bring his head into line and bring his head up until his nose and his chin are in a straight line. This big. All right, mate.
Now you need oxygen and a collar for the casualty's neck. The sooner you have these items, the better. Ensure the collar is the correct size, and when fitting it, be careful that you don't twist the casualty's neck. Keep it as still as possible.
I'm just going to put this round the back. You'll feel me going round the back of your neck.
Be very careful when moving victims in this situation. You have to roll the casualty into the stretcher without moving their spine. Keep their neck supported at all times. The stretcher must have a stiff surface, not a canvas one. If the stretcher is not stiff as required, add a plank or wooden board. It requires careful coordination, with one person calling out the instructions. Make sure you have plenty of help. You can't do this on your own. Once you have brought the casualty to safety, check for shock. You must reassure them. Remember how frightened they will feel. Shine a light in their eyes. The pupils should contract. If they don't, the reflexes and nerve endings may have been damaged. Keep repeating the procedure to see whether there is any response. If not, radio for assistance. Return to the casualty and carry out their recommendations. The most common form of muscle injuries are strains and sprains, which are nearly always caused by falls. With sprains and strains, the injury will swell a little after the accident. This is caused by the tissue bleeding internally. It can be hard to tell if a fracture is present as well. With a fracture, it may hurt a little away from the site of injury if pressure is applied. If you're in any doubt, fit a splint. Otherwise, put the casualty in their bunk and raise the injured part. Your next step is to reduce the swelling with the application of a cold compress. The best method is an ice pack, held firmly in place by a bandage. But a packet of frozen peas will do just as well. Put it on for 20 minutes. Repeat at least 3 times a day for 48 hours. Make sure there's no direct contact between skin and ice. The patient now needs to rest for 2 to 3 days, or longer if the injury is severe. They must keep the injured part elevated, but they must also be encouraged to move the injured part as long as you're sure there is no fracture. It's better to have early movement than too much rest. Apart from accidents, you could have to deal with many other surprise situations with the potential for serious harm or even death. For example, diabetes is a common condition and a sufferer could require your help. When a diabetic's blood sugar falls below normal, the whole body is quickly affected. The condition is called hypoglycemia. The early signs include weakness, faintness, and hunger. There might also be palpitations and muscle tremors. Strange behavior is another indication. As the condition worsens, the level of response gets worse. A person with hypoglycemia may become incoherent and possibly aggressive. The breathing becomes increasingly shallow.
Some chocolate and stuff.
In your cabin.
Look at the casualty's skin. It may be pale, cold, and clammy. The pulse will be strong and bounding. But you don't need to check every one of these signs. Most diabetics in the early stages of hypoglycemia will be able to tell you what's the matter. Many sufferers carry some evidence that they're a diabetic, such as insulin, a syringe, a chain, or a bracelet. If they show the signs but don't know that they're diabetic, you must get medical help. The treatment is simple. Sugar. Preferably a sugary drink, but you must act quickly before the patient becomes unconscious. You can give sugar on its own or in the form of sweets, sugary biscuits, or cake. The casualty starts to improve within minutes. If they don't, or if they become unconscious, you must radio for medical help immediately. Dealing with an epileptic fit is another situation you might come across. This is another condition that looks worse than it actually is. While the fit is happening, move any furniture and sharp edges on which they could hurt themselves. In nearly all cases, don't move the casualty, but when you have to, you should use the correct techniques. The casualty may become rigid, arch their back, seem to lose all awareness of their surroundings, and go into a state of muscular spasm. Do not interfere, but do loosen the clothing around the casualty's neck, if this is possible, or put something under their head. Do not try to restrain them, put anything in their mouth, or move them, unless they're in danger. You should make a note of the time and duration of the attack. When the convulsions have finished, the casualty usually relaxes into a deep sleep. Stay with them, placing them in the recovery position until they've fully recovered. When, as here, the person knows they have epilepsy, they will be the best judge of whether they need medical attention. But if a casualty doesn't know, or it's the first attack, they should see a doctor. Once in port, don't let them go off on their own anywhere until you're quite satisfied they are fully recovered. You may have to assist a casualty that has developed an allergic reaction. Substances that are harmless to most people can have a strong effect on certain individuals. Food allergies, insect bites and stings, or other substances entering the body by inhalation, swallowing, skin absorption or injection may cause an anaphylactic shock.
Here, and then I'll go get some help, okay?
Okay.
Unless the casualty has their own treatment, medication for allergic reactions should only be used after obtaining radiomedical advice. One such allergic reaction with alarming symptoms is asthma. The most obvious signs of asthma are that the sufferer takes a long time to breathe out and may make wheezing noises. In some cases, the casualty will be seriously distressed and have difficulty in speaking. They may even start turning blue and suffer exhaustion from the sheer effort of breathing. But in nearly all cases, the sufferer will have an inhaler. Ask them where it is and get them to use it. If they don't have one, or if it's a first attack, get radiomedical advice. Chemical spills to any part of the body, but especially the eyes, need swift action combined with a cool head. The eye is a very sensitive area to deal with, and care should be taken not to aggravate the situation further by bad handling. Remember to check first for dangers to yourself and your casualty. Your first priority is to flood the eye with running water as quickly as possible. Use water bottles, which should be located around most chemical handling areas or the nearest wash area. Go to the nearest source at once. Bathe the eye for at least 10 minutes. If it's more convenient, use a glass of seawater. Take care that contaminated rinsing water does not flow from the affected eye to the good one or onto your skin. Meanwhile, the spillage must be cleared and the area made safe. Use the right protective gear and make sure that you're not the next victim. Even when you've brought the victim safely below, you must continue to flood the eyes with water for 10 minutes at a stretch, several times. Just once isn't enough. It will also help to ease the pain. Reassure them. Eye injuries are especially frightening because the victim can think that they will be left blind. In between washing the eyes, test their vision. When you get radiomedical help, the doctor will want to know how badly their eyesight has been affected. Simple tests like this one are fine. Then continue with the water treatment.
One of our engineers has splashed his left eye with 10% caustic soda at 1100 hours GMT.
Do not attempt any further treatment before taking advice from the doctor. In most cases, the doctor will tell you to cover the eye with a sterile eye patch. Don't use anything made from fluffy fabric because strands of the fibers will irritate the eye. Also, add a pad to the good eye. This will prevent movement of the eye and further damage. Stay in regular contact with the doctor, who will instruct you depending on how the victim progresses. The other common eye condition you may have to deal with is arc eye, when an unshielded victim is exposed to a sudden burst of light from a welding arc. This may develop during the next few hours and is frightening because the victim may temporarily lose their sight completely. There may be pain for a period of about 12 hours, so the most important thing is to reassure them. It isn't necessary to flood the eye as you would for a chemical splash, but you do need to test the victim's vision and report your findings to the shore-based doctor. You may be told to fit a sterile eye patch. The doctor will also want you to retest the casualty's sight after 24 hours. Otherwise, the treatment is rest. In most cases, normal vision returns a few hours after the incident. Poisoning accidents can take many forms. Among the most common are incidents where an industrial liquid is swallowed by mistake. What can complicate these accidents is not knowing what the victim has swallowed. So one of your first priorities must be to identify the substance and keep it.
Yeah, he drank some of this stuff, and I don't think it's beer.
With an unconscious patient, you would monitor ABC and be ready to resuscitate. If they're conscious, help them to rinse their mouth out thoroughly. This will at least flush away any toxic residue still present. In all cases, radio for medical advice immediately. If they vomit, keep a sample. It may eventually help to identify the poison.
Take it easy. And again.
Head injuries are dealt with in detail in the booklet that accompanies the video. If there is an open wound, do not press down on it because there's always the possibility of brain damage. Don't poke around in the wound or attempt to remove bone fragments. Apply ABC, get the patient below, and seek radiomedical advice immediately. Hypothermia is the leading cause of death among shipwreck survivors. If the body has plunged into cold water for a period of time, the body's heat production will automatically increase in an effort to balance the heat lost. But if heat is lost faster than it's produced, the body temperature will fall and hypothermia will result. The casualty will be pale in color and exhibit frequent muscular rigidity, shivering, and varying levels of consciousness and shock. Treatment for hypothermia will depend on the condition of the survivor. Those who are rational, capable of recounting their experiences, and are still shivering, can be re-warmed in a warm bath at around 40 degrees C. Keep them with arms and legs submerged, or in a shower sitting backwards with knees up. Remember that even conscious survivors can collapse and become unconscious shortly after rescue. And never give the casualty alcohol. In more serious cases, where the survivor is not shivering and is semi-conscious or unconscious, you should immediately apply first aid measures. On rescue, check the casualty's breathing. If the casualty isn't breathing, start artificial respiration immediately. If the casualty is breathing but unconscious, lay them in the recovery position. This is necessary to ensure that their breathing is not obstructed. At this stage, avoid all unnecessary manhandling, even removing their wet clothes. Wrap the casualty in blankets, preferably keeping them horizontal with their head slightly down. The final part of this video is about moving casualties on board ship. As a general rule, you only do this at sea. In port, it is better to wait for the ambulance to arrive. Only move the casualty in a life-threatening situation. The three-handed seat is easier both for the helpers and the casualty, but the casualty must be conscious and able to cooperate. The two helpers join their wrists in a T-junction. The casualty then uses this as a seat. The helper with the spare hand can then use it to steady the casualty's back. Alternatively, he can support a broken limb with it. For the casualty, this is a comfortable and reassuring way of being carried. For going up and down stairs, use the fore and aft lift. Even more comfortable is the four-handed seat. The two helpers join both wrists together, forming a kind of bench, but it means there is no spare arm left to steady the casualty's body. In a very confined space, use the drag carry method. The casualty lies on their back and puts their arms around your neck. Tie their hands together if they're unconscious. Then crawl along using your neck and knees to drag the casualty with you. It's much easier if there are two of you. The helper at the back carries the casualty's legs so that he's kept off the floor. In some situations, the only way to get a casualty away from the place of the accident is to lift them vertically. For this, the best method is the Neil Robertson stretcher. If the victim is unconscious, they will require oxygen, suction, and cervical spine immobilization. Tie their ankles and knees with a bandage. The third helper places the casualty's wrists around the second helper's neck. Then, One helper stands astride the victim's legs with their right hand under the left calf and the left under the right thigh. The helper at the head is the one in charge. The second helper stands astride the chest and clasps their hands underneath the victim.
Prepare to lift.
The stretcher should be ready close to the casualty's head with all straps unfastened. If you suspect spinal injury, you must ensure that the spine is kept straight and that the neck is supported, not allowing it to twist. The stretcher can now be strapped up and the casualty removed. If the victim is to be carried, you must have 4 bearers. If they're to be winched out, take care to keep their bodies straight as you attach the stretcher to the winch. There should also be a rope from the bottom of the stretcher which allows you to steady the stretcher as it goes up. Armed with the techniques you've learned in this series, you are in a position to make a real contribution to your shipmates' well-being and survival. Further information on many of these topics can be found in the accompanying booklet. And remember, in any situation, you have to be calm, be persistent, and attentive. These are the keys to success.